So we started with the intrauterine septum incision surgery. We identified the internal os, went 1.5 centimeter above the internal os, and with the tip of the Collins knife, we used 18.5 French bipolar hybrid Arbe resectoscope with a Collins knife, and we cut with the tip of the Collins down. Now, when I cut the tip with the tip of the Collins down, at one point I could see the gas bubbles coming, air bubbles coming from the other cavity. That was the point where the cavity must have got opened. So we proceeded with the tip of the Collins knife. We started cutting the wall contralateral to the right ostia because we could not enter the left cavity. We could not identify. As we cut, there was a thin layer. We showed that this was the point where the other cavity would be opened. And we opened the other cavity. We entered the other cavity, and then we started the septum incision from caudal to cranial side, keeping in mind the landmark ostia. We went from the one side of the septum to other, and also just touching the intervening tissue and pressing the electrosurgical unit pedal. We used a cutting current. We used a pressure of around 70 millimeter, gradually increased till 100 millimeter of mercury with a flow rate of 300 ml per minute. We always kept eye on the ostia. We could see the other cavity ostia also from here. The landmark in septal surgery should be always ostia. That's the point where you should end your surgery. Always, when you are confused, come at the level of internal os, review your surgery, look at the ostia, and then proceed again. So gradually we proceed with the septum incision. I don't call it resection, I called it as septum incision because we are incising the septum. We are not resecting it out. That's a misnomer. So we started doing it septum incision till we could see both the ostia nicely. Remember one thing, the septal surgery, we should always undercut the septum rather than overcut the septum. In a normal uterus, remember one thing, the fundus is always convex. So there is a margin, there is a big distance from the interosteal line to the fundus. However, in this case, when we did a laparoscopy and when we did a 3D transvaginal sonography, we could see a flat fundus. That means the distance between the interosteal line and the fundus was less. So if we cut more, we are destroying a normal tissue also. So remember one thing, here it's a two-dimensional. We are not doing a laparoscopy. It's always better to undercut rather than overcut. Otherwise, you are going to destroy the normal tissue or you might perforate. As it is, we always tell all the patient of intrauterine septum incision surgery to undergo recheck hysteroscopy 6 weeks after primary surgery. So here we are doing the septum surgery. We could see the left ostia, the other cavity nicely. We could see the right ostia also. Gradually, these are the gas bubbles generated due to the action of the electrosurgery onto the tissue. And we started cutting the later on the lower part, that is the caudal part, till the internal os. Now we should continue this cutting till I could see the contralateral wall, that is left lateral wall of the uterine cavity nicely. So we continued the surgery, and gradually at one point we could see the lateral wall nicely. We could see both ostia just above the internal os. Yes, we could see the left ostia. That's the point. I think that's the end point. Yes. That's we could see the lateral wall, the left lateral wall nicely seen. Yes, see the left lateral wall is seen. Yes, it's not nicely seen. So that's the end point. We could see the left ostia nicely. We could see the right ostia also. That's the left ostia. That's the right ostia. And the incision is exactly at the interosteal line. Now, this is the picture of a normal uterus which shows increased distance between the interosteal line and the fundus. In a intrauterine septum, the fundus is flat, so distance is less. So don't do a more dissection or incision, undercut rather than overcut. Thank you.